Hello guys, today we are going to continue our set of lectures about pathology of endocrine system. It's our last lecture. Here let's talk about parathyroid glands. We already a little bit discussed about about thyroid gland pathology. We discussed all the types of thyroid gland pathology. We discussed what the Hashimoto disease. We discussed what the Graves disease. Yeah, have we discussed it? Graves disease, no? Yeah, we discussed it, I guess. Yeah, I remember we discussed it. So now we will discuss the parathyroid gland pathology. So parathyroid glands, according to histological view, so we remember that we had chief cells there and oxyphyll cells. Oxyphyll cells function is unclear, so that's why even if we have any tumor of these oxyphyll cells, we don't see any changes, and that's why we don't mention this disorder, and we don't treat it like disorder. So that, but if we talk about chief cells pathology,
The screen is not sharing.
yes,
So your screen is not showing.
not showing. It's showing. Okay, I
No,
can
sir.
check it again. So oxyphyll cells, they have no exact function, and we didn't understand it. So let's talk about parathyroid gland function again. So as we discussed, so function of parathyroid glands, especially sheath cells, to produce a parathyroid hormone, and these functions include increased renal tubular reabsorption of calcium to increase the calcium level in plasma, increased urinary phosphate excretion, thereby lowering serum phosphate levels. So you see, it really decreases the phosphate level, which liberalize calcium from the bones. So it additional feature by which we increase the level of calcium in the blood. Then increased conversion of vitamin D to its active dihydroxy form in the kidneys, which in turn augments gastrointestinal calcium absorption. So by this feature of conversion of vitamin D, we activate enzymes which cause it conversion of vitamin D. So it leads to increased calcium absorption from digestive tract. So from our small intestine, first of all. Enhanced osteoclastic activity. So we discussed osteoclasts. They are macrophages of bones. They cause activation of acidic phosphatase, and this acidic phosphatase causing the destruction of deposed calcium phosphate in our bones. And due to this, yeah, of course, calcium level increases, because while we resorb it, so calcium returns into the blood, and you remember return back, this phosphate level decreases. Yeah, phosphate level decreases due to same hormone, but calcium phosphate is resorbed, and then phosphate is removed by urine, and then remains only calcium ion. Yeah, and all these options are responsible for calcium level increasing in our blood. In our blood tissue. So what's the physiological role of calcium? Might be you discussed it in physiology, might be not. Calcium is taking part in a lot of different processes in our body, like coagulation of blood. It also takes part in muscle contraction, and of course calcium level. So and bone deposition of calcium is present, also present for restoration of bone. So and sometimes we need to increase this calcium level. Also, calcium takes part in our osmotic pressure. So regulator of osmotic pressure. They take part in pump activity, in nervous system transmission. So calcium plays very important role in a lot of different types of activities. Okay, someone trying to join but late. Okay, then. The net result of these activities is an increase in the level of free calcium in the blood, which inhibits PTH secretion from chief cells. So you see, we have a feedback. We have a negative feedback here. So if calcium level is already increased, we have negative feedback, which causes a decrease of PTH secretion. But abnormalities of parathyroid glands, it mainly or tumor or lack of PTH secretion. So mainly, so now we'll discuss tumor. Hyperparathyroidism. Hyperparathyroidism means so increased production of parathyroid hormone, so without negative feedback, without proper negative feedback. So so you can even now you can suggest what happens due to increased parathyroid hormone. Okay, let's discuss it step by step. Okay, we have primary hyperparathyroidism. It's a common endocrine disorder, and it may be important cause of hypercalcemia. So this is it's a genetic lesion, of course, genetic lesion. So it happens first of all due to adenoma, 85 till 95%. Almost in all cases, it's a benign tumor. Sometimes it's primary hyperplasia, so which is might be diffuse or nodular. It's 5 to 10% pretty common. And carcinoma is much less common. It's only 1%, might be even less. Percentage of parathyroid carcinoma, because as same as in thyroid gland, same as in the pituitary gland, it is located out of digestive tract, out of connection with outer environment. That's why these tissues are pretty safe against noxious stimuli, which can cause a cancer, which can promote the hallmarks of cancer. Okay, pathogenesis, so it's same, almost same, yeah, it's specific, but you want to gonna remember it. So, for example, cyclin D gene rearrangements, so you remember the cyclin D, cyclin D1, it takes part in a process of cell cycle. And in parathyroid gland, so somehow even only this cyclin D1 is responsible for its growth, and also min1 mutation. So it's a tumor suppressor gene, and the mutation of this gene causes a decreased activity of anti-tumor activity. So, but it's a benign tumor anyway, so we used to survive, but still we have a lot of bad outcomes of this tumor. Okay, morphology changes in primary hyperparathyroidism include those in the parathyroid glands and in other organs affected by hypercalcemia. You see, so most commonly it's adenoma. Typical parathyroid adenoma is well circumscribed, soft, tan nodule invested by a delicate capsule. So, as I said, benign tumor. If we have capsule, it's nodulated structure, so we can easily say it's benign. Parathyroid adenomas are confined to a single gland. Yeah. Usually it affects only one gland, so not all glands, all parathyroid glands. I remind you, there are 4 parathyroid glands in our incrustated inside the thyroid gland, so that's our present. Okay, this is technetium test result, so by which we insert technetium and then check the radiation, so which is collected there. So it demonstrates an area of increased uptake corresponding to the left inferior parathyroid gland. So this is, now you see density of signal is much higher than in these areas, and it happens when increased blood circulation happens in this area, and it absorbs much more. It absorbs much more technetium than other parts. Okay. This is histological structure. Of course, this sheath cells. This is sheath cells adenoma. So you see, its adenomatous structure is preserved. Adenomatous structure is preserved. So you see, it's like circles, somehow resembling the thyroid gland, but without colloid in the middle. Yeah. And increased, very large tumor is shown here. So cells with bizarre and pleomorphic nuclei are often seen within adenomas and endocrine atypia. So if you're not going to be pathologist, so it's not very necessary for you. If you're going to be pathologist, you'll read it by yourself. Yeah. Okay. Typically is a multiglandular process. So in some cases, enlargement may be grossly apparent in only 1 or 2 glands, complicating the distinction between hyperplasia and adenoma. So you see, adenoma, it's when one cell lost their min1 or maybe cyclin D1, yeah, process is mutation happens, so it will be adenoma. But hyperplasia, so it's when it's overstimulated gland, yeah, it's overstimulated gland, so it leads to it leads to growth of all glands, all parotid glands. So carcinoma very rarely happens, and actually we can skip it. Morphologic changes in other organs. So which changes we expect in a increased parathyroid gland secretion, parathyroid hormone secretion? Of course, skeletal changes. You remember, normally in a bone, so we have this process, yeah, when osteoblasts producing the bone, osteoclasts resorbing the bone, and then resorption of bones is followed with bone formation. By this, our bone structure is renewed, yeah, so new bones are produced, new structures, osteons are produced, yeah, and you know that senescence of bone is made by fractures, so microfractures. So we do every day, every time you walk, every time you do the tendon to muscle, it leads to microfractures in bone. And to restore it, yeah, we need to remove previously formed bone, fractured senescent bone, and replace it with a new bone. And this process is going normally under control of PTH. As I said, osteoclasts are responsible for resorption of bone, yeah, osteoblasts for bone formation. And osteoclasts are active if the activity of osteoclast is higher than osteoblast activity. So of course, which changes will be there? Of course, it will lead to osteoporosis, known as osteoporosis. Okay, then let's check what they see here. Include increased osteoclastic activity, which results in erosion of bone matrix and mobilization of calcium salts, particularly in metaphysis of long tubular bones. And the bone resorption is accompanied by increased osteoblastic activity and the formation of new bone trabecula. In more severe cases, the cortex is grossly thinned and the bone marrow contains increased amounts of fibrous tissue accompanied by foci of the hemorrhage and cysts, and is known as osteitis fibrosa cystica. Aggregates of osteoclast, reactive giant cells, and hemorrhagic debris occasionally form masses that may be mistaken for neoplasms. They are named as brown tumors, typical for hyperparathyroidism. So you see, along with the activation of osteoclast, we have activation of osteoblast activity too, and they produce more fibrous tissue because calcium is resorbed from the bone. And these connective tissue structures, so they can resemble the tumor, and this is typical brown tumors. Of course, you can't observe it with ultrasound or X-ray, so this may be found only due to pathological examination. Then renal changes. Now, renal changes, of course, it's understandable. We have a calcium ion. You remember from chemistry that calcium ion has a lot of opportunities to make a stone, to make insoluble salts in our body. And for example, they are oxalic acid. Yeah, we have oxalic acid which is produced during the Krebs cycle, and oxalic acid is residually happens in appeared in our plasma. And calcium binds it with the formation of oxalate, calcium oxalate, and this calcium oxalate causes the formation of stones in the kidneys, the first forming kidneys. Also, not only oxalates might be present, so might also phosphates. So due to increased removal of phosphates, and along with it calcium is released. Of course, it also leads to formation of calcium phosphate stones, and also they are much less commonly present because amounts of phosphate is not so high, but also it is possible. Also, we have calcium related stones are like uric acid stones, ureates, yeah, calcium ureate. Uric acid, so I remind you, it's derived from DNA or RNA. It's uric acid derived from purines, and this in purine metabolism, so they are metabolized till uric acid and should be excreted by urine. Okay, 1 minute. And these stones can obstruct the urinary flow, and that can cause hydronephrosis and typically hydronephrosis when this stone goes out. So about kidney pathology we'll discuss in another semester. So the stones are very commonly happening. Okay, and also interstitium of kidney also can be calcified, so it's known as nephrocalcinosis, but it's not only for kidney, and as it's shown here, metastatic calcification is a secondary to hypercalcemia, which can be happen in every parenchymal and even non-parenchymal organ of the body. Everywhere we have a site where potentially calcium can be absorbed, so it causes calcification, especially dangerous it is in blood vessels. So if a patient already had atherosclerosis, so if atheromous plaques are present, in case of increased calcium level there, it leads to calcification of this plaques, and of course it leads to thrombi formation in future. So that's why calcification, so increased calcium in the blood is also dangerous. Clinical features. Hyperparadism usually is a disease of adults and is much more common in women than in men. It's 4 per 1. So especially this has happened after. So why females are more involved? Especially happens after menopause. So you see. After menopause, so because some portion of calcium control of the body, so for bone consumption of calcium is responsible for estrogens. So and estrogens which are present, which are present during the normal before menopause life. So it controls the normal calcification of bones. But after menopause, so estrogen level is decreased, and that's why even if females had hyperparathyroidism, we didn't mention it. And we just didn't get clinical signs of it. But it's became very obvious in females after menopause. That's why this gender ratio is 4 and 1. Might be males and females are affected similarly, but in males testosterone, which also take part in calcium exchange in the body. So, but testosterone level is almost always on the same level. That's why we much rarely see this hyperparathyroidism. We don't mention it. You see, it doesn't mean we don't have it, but we don't mention it because symptoms are like hidden, obscuring by hormonal activity of male and female hormones. In males, it's obscuring much better. So the most common cause is hypercalcemia through a variety of mechanisms, including secretion of PTH-like polypeptides and osteolytic bone metastasis. So that's why don't think that if you have increased calcium, it is always because of hyperparathyroidism. So sometimes increased calcium level might be related due to tumor. And in first group we'll discuss this feature in pancreas tumor, for example. Mahnur said this presentation today, very interesting presentation. In pancreas tumor, it leads to resorption of bone without parathyroid hormone. So this because the metastasis, they very aggressively resorb the bone, and calcium phosphate, which is released there, is not related to PTH. And it leads to osteolysis. Okay. So let's talk about symptoms, which are additional symptoms. They include gastrointestinal disturbances, central nervous system alterations, neuromuscular abnormalities, and polyuria. Let's discuss all of them. Gastrointestinal disturbances, they are including constipation, nausea, peptic ulcers, pancreatitis, gallstones. All of this is related due to damaged smooth muscle activity. So because all of this is based on calcium level, and increased calcium level causes the overactivity of smooth muscles. That's why might be present constipation, nausea, peptic ulcers. Because not abnormal contraction of smooth muscles happened. Gallstones, by the same reason as in kidney stones, but much rare than in kidney. So because gallstones are not stuck on calcium level. Then central nervous system alterations, including depression, lethargy, and seizures. Of course, calcium takes part in normal neurotransmission. So because you know that in synaptic node we use the calcium consumption for releasing of secretory granules. That's why in increased calcium level, of course, first of all you see seizures, might be depression, and lethargy in severe cases, in most severe cases. Neuromuscular abnormalities, it leads to weakness and hypotonia. Of course, if you know that skeletal muscles, they work on the differences between calcium level in cytoplasm and in sarcoplasmic reticulum, and if calcium exchange should be happening with a very aligned system, and calcium in the cytoplasm should be much lower than in the sarcoplasmic reticulum, and calcium level should be increased only after neuromuscular junction activation. But if neuromuscular junction is not active but calcium level is preserved in cytoplasm due to penetration through the calcium channels, so it leads to dumping of process known as relaxation of muscles. So that's why muscles cannot be properly relaxed, and of course if they are not relaxed, so it leads to weakness, and hypotonia happens after it. Then polyuria and secondary polydipsia. Polyuria, so due to same reason, so calcium level increased, so osmotic pressure increased, and due to this more urine is released, and due to this patient feels thirsty, and drinking of a lot of water is named as polydipsia. So it's related to hypercalcemia. So okay, secondary hyperparathyroidism. It's caused by chronic depression of serum calcium levels, most often as a result of renal failure leading to compensatory overactivity of the parathyroids. So you see, it's a hyperplasia. Yeah, so it's typical hyperplasia when chronic consumption of calcium, decreasing of calcium, leads to overactivity of the parathyroid gland. And here we see that it's hyperplasia, just hyperplasia of this parathyroid glands. It is not related to genetic disorders. It's usually related, as it's shown here, to renal failure, where most of calcium is released by urine. Okay. Sorry, I have transfer. So we can say that clinical manifestation includes, of course, secondary hyperparathyroidism. It's VO is dominated by main disorder. So main disorder usually renal failure. Usually renal failure it is, and calcium is absorbed. Calcium is not properly removed from the body, so that's why it leads to it's improperly released from the body, and that's why PTH is subsequently increased, and due to this now it's hyperplaced. Okay, summary we discussed. Okay, hypoparathyroidism. So hyperparathyroidism most commonly happen due to surgical ablation. So when during the thyroid gland surgery, thyroidectomy, so we remove not only thyroid gland, but very commonly we remove also parathyroid gland, because it's almost impossible to save it. So that's why during the surgical ablation, parathyroid gland can be decreased. So that's why future surgeons take care about it and prevent the damaging of parathyroid gland, or control calcium level. Then congenital absence. Congenital absence very rarely happens in DiGeorge syndrome. So we discussed it in genetic abnormalities a little bit. And then autoimmune hypoparathyroidism is very rarely happens. So it happens due to mutations in autoimmune regulator, IRE, gene. Later we'll discuss it in polyglandular disorders. Then pancreas. Endocrine pancreas. So we know that pancreas is a portion of digestive tract. It produces enzymes, hydrolytic enzymes, which are responsible for normal destruction of carbohydrates, fats, and lipids, and also proteins, of course. Proteolytic enzymes like trypsin and chymotrypsin, lipases are present, and amylases are present there. So, but in pancreas we also have some additional few cells, actually few portions in pancreas, which are named as islets of Langerhans, and I hope you discuss it. And islets of Langerhans are responsible for secretion of insulin and glucagon. And they are very closely related to formation of insulin. Very closely related to level of glucose in the blood. Due to increased level of glucose, produced insulin. Due to decreased level of glucose, produced glucagon. There, so we have beta cells, alpha cells, and PP cells also. So with delta cells also named. So they produce somatostatin and pancreatic polypeptide. So it's less important for us. Much more important for us is insulin, of course, because it leads to formation of diabetes mellitus. So diabetes mellitus, it's hyperglycemia, which has happened due to insufficiency or improper work of insulin, and it's chronic hyperglycemia. So diabetes mellitus, we have two types of them. So type 1 and type 2. Type 1 and type 2. Type 1 is happened due to usually in the childhood period, and when patient doesn't have islets of Langerhans, which are producing proper amount of insulin, and that's why any glucose what's the work of insulin? So let's discuss work of insulin. Insulin actually stores. Insulin is a hormone which causes activation of different organs, mainly liver, to absorb glucose from the bloodstream, from the plasma, into the liver tissue, inside the liver cells, and production of glycogen in the liver, so which is a it stores before in case of fasting. Yes, in case of fasting we use this glycogen to increase the glucose level. Glycogen can be resorbed with the help of glucagon or glucagon-like factors, and main glucagon-like factor which causes the destruction of glucagon and increasing of glucose level in the blood, so it is adrenaline or epinephrine, and we a little bit discussed about it in histology. So you see, and then storage. So why we need the storage? Why calcium? Why glucose level is dangerous for us? Actually, increased glucose level, chronic increasing of glucose level leads to different outcomes. But just let delve deeper. So in the first lecture of previous semester, I explained you the cell membrane structure. I explained you the antigenic function of cell membrane. Yeah, and you remember that we have this MHC molecules, MHC1 and MHC2. So it doesn't matter which one we are talking about. So MHC is antigen structure, and it contains glycoprotein. And this glycoprotein can be glycoprotein. So you remember that from chemistry you should know that glucose part of any glycoprotein or glycolipid, so it doesn't matter, any of this carbohydrate portion of any molecule can be interacted with another carbohydrate, and glucose is carbohydrate, and that's why it can be interacted with it, and might be bound with it, covalently bound with it, with O-glycoside, 1,4-O-glycoside bond. And you see, antigenic structure of cells which are encountered with a high level of glucose might be gradually changed. gradually changed. And what happens when some membrane changes antigenic structure? Of course, it become autoimmune activity against it. We have autoimmune activity against these cells which are affected with the increased glucose level, and that's why what happens. So which organs are first affected? Of course, they are blood vessels and small blood vessels, so capillaries. They're affected because glucose stored there, and antigenic structure of capillary endothelium is changed, and side cells also changed. And that's why first of all we mention complications of diabetes mellitus on the in the tissues with small capillaries. They are like retinopathy, so which leading to blindness later. So I oversimplify it, but you see, when blood vessels are injured, you remember what happens. Activation of thrombosis happen, and thrombi stuck this small capillaries, so of eye, so which leads to retinopathy of the eye, so this diabetic retinopathy. So secondarily, it can affect small nerve endings, so like finger, tip of finger, so where we have a lot of nerve endings there. So and due to improper circulation of blood in the tip of finger, it leads to neuropathy there, and due to this sensitivity of nerves are decreased. Okay, then also we can say about tools. Yeah, so in tools very commonly it happens in tools, but microcirculation damage is there, so it leads to, yeah, first of all, of course, decreased sensitivity there, but no one mentioned it. No one mentioned that his tool doesn't feel pain. Yeah, so everyone is happy with it. But when you injure it, you don't mention it. Yeah, so when some infected needle or any infected nail, yeah, so come there, it leads to infection, but patient usually don't remember, don't feel it, and don't do some prevention methods against it, and this bacteria causes the formation of gangrene. Yeah, gangrene of the first of all tools, so sometimes the entire foot, leg, and that might be the cause of death. Also kidneys are affected due to diabetes mellitus because of glomerular apparatus of kidney. As you remember, it contains a lot of capillaries, and this network of capillaries also get damaged, and leads to formation of microthrombi in a kidney, and due to this circulation there is damaged, necrosis of capsules happen, necrosis of tubules happen, and leads to chronic kidney disease, so in diabetes mellitus. And we have a lot of other infections, so we can talk about every site of our body which is affected due to diabetes mellitus. So, but I hope even this information is enough to understand that diabetes mellitus must be handled, and only one thing we can do with diabetes mellitus is the controlling of glucose level. You have to always check the glucose level and correct it with injections or with a treatment or with a diet. So okay, let's talk about two types of diabetes mellitus. So type 1 diabetes mellitus so is usually related to beta cells of islets of Langerhans, which produce insulin. It might be related, it's congenital, might be congenital, so with aplasia of these cells, or might be acquired. It's acquired due to pancreanecrosis, for example. When you had when in case of acute pancreatitis, if it's untreated, and in severe case of pancreatitis, it leads to necrosis of tissue of pancreas, and beta cells are also destructed, and this leads to type 1 diabetes mellitus. And of course insulin cannot be produced, and from this you can imagine so what we should do. Of course treatment is simple, so just injection of insulin when it's necessary, just checking of glucose level of blood, and injection of insulin regarding the needed amounts. Okay, But type 2 diabetes is happened due to another reason. It happens due to peripheral resistance to insulin. So it is related to usually to increased consumption of carbohydrates. Increased consumption of carbohydrates. That's why usually persons who are affected by type 2 diabetes mellitus, they are pretty fat. They have obesity. Yeah, they have obesity because of increased consumption, but increased. But this adipose tissue, so now it replies to the action of insulin. So as shown here, so insulin works not only on liver, but it also affects the striated muscles and also adipose tissue. And then when a person eat a lot of carbohydrates, a large load to the bloodstream, a large load to beta cells happen to insulin. Beta cells produce a lot of insulin, and this lot of insulin work on the surface of the cells, on the membrane of fat cells, adipose tissue, on liver cells, on muscle cells. And if we have a lot of adipose cells, so this insulin doesn't act properly. So you see, is insulin bound with it, but it has no action because in liver all stores of glucose is stuck. So with glycogen in muscles, consumption is limited. Yeah, and that's why if liver doesn't take glucose, striated muscle doesn't take glucose, so insulin goes to adipose tissue, and then adipose tissue tries to take uptake of glucose to reform it in fat, but it cannot handle it because a large amount of insulin leads to decreased production of insulin receptors. Then insulin receptors all over the body, and in liver, and in muscles, and in adipose tissue are decreased due to increased the amount of insulin. That's why it doesn't matter how much insulin is produced, receptors are decreased in amount, and these receptors cannot carry this amount of carbohydrates. And of course, it's and also due to overproduction of insulin, beta cells. So in beginning they are hyperplaced, hypertrophied. But secondarily, due to overactivity, these beta cells, or even beta cells which produce insulin, they became atrophied, gradually atrophied. So that's why yeah, take care about your consumption of carbohydrates. That's why it's everywhere recommended not to eat too much carbohydrates. Also, of course, here we have some genetical component in this disorder. In some persons, this insulin production and receptors of insulin production is okay. Doesn't matter how much they eat. Yeah, but yeah, some persons with even little uptake of glucose, so they these beta cells can be insulin receptors production can be decreased with the time, with the senescence of the body. And that's why diabetes mellitus type 2 usually happen after the age of 40, 50, 60, when yeah, typically happens the senescence of all mechanisms of the body, and particularly here beta cells of Langerhans islands. Okay, it's a relative insulin deficiency. Okay, I already explained the general pathogenesis of this. So capillaries, you see, capillaries, in case of obesity, happens the hypertrophy of the hypertrophy of beta cells, which produce normal, so which cause increased production of insulin, and then normal or impaired glucose tolerance happens here. But later, the same beta cells cause the destruction, failure of beta cells, and it leads to diabetes mellitus. Usually, its onset is pretty acute. I mean, patient mentioned that he has some disturbances in 1 month, 1 week, 1 month. He gained his weight for years, but he figured out that something wrong with him in 1 month. Okay. Here, in general, I explained it. So, what is insulin resistance? What is the best in insulin resistance? We discussed before. So, please, here it's written. You have this book, so please read it by yourself also. I explained it before. Um, okay, other forms are not interesting. So acute metabolic complications of diabetes. Yeah, another complications we have. So due to deficiency, utilization of glucose is injured. Utilization of glucose happens by injured pathway, so which leads to ketoacidosis. Ketoacidosis, it's ketone bodies are produced. Ketone bodies are produced, so which cause the abnormal collection of these ketone bodies in brain and other fat-like tissues, especially in brain. Yeah, of course, it's causes the brain and it can cause the coma. Okay, diabetic coma or ketoacidotic coma. So, by which symptoms you can suggest that patient has diabetes mellitus? Of course, it's polyuria, polydipsia, and polyphagia. So this is classic triad of diabetes. So polyuria, so increased removal of urea. So because of, I said before, because of increased osmotic pressure in the blood, so glucose is not, you remember that during the kidney function, you remember that most of glucose is reabsorbed in distal proximal convoluted tubules. But in this case, concentration of glucose is so high that proximal convoluted tubules they cannot reabsorb this glucose, and then this glucose continues their travel through the loop of Henle and distal convoluted tubules. And there in loop of Henle, you remember that osmotic pressure regulation happens, and reabsorption of water happens regarding the concentration of compounds in urea, in primary urea, and then reabsorption happens in larger amount in case of glucose in urine location, and it leads to polyuria. Of course, and you can find glucose in urine also. Then we have polydipsia. Polydipsia in the higher consumption of water, because thirst of the patient, because a lot of urine is lost, so that leads to a larger consumption of urine, of water, sorry, and a larger production of urine, of course. And then polyphagia. So then a patient with this in this condition, they cannot feel that they are full of food. They don't eat enough. One minute. So they don't feel that they ate enough because glucose level is high. Yeah, but use of this glucose is injured. Use of this glucose is challenged. So in this metabolic derangements leads to polyphagia. So this person try to eat more, but use of this glucose is challenged, and that's why even a person eat a lot, drink a lot, but he doesn't gain weight. Now, usually first symptom of diabetes mellitus, especially type 2, is a loss of weight. Usually this fatty person, very obesity person. So, but it is continued that the person lost his weight, but he doesn't feel better because of it. Since insulin is a major anabolic hormone, its deficiency has widespread effects. Okay. So which effects we have? In case of so it has effects to adipose tissue, and this glucose is rearranged into fat, yeah, triglycerides. Then in muscles, so it activates the muscle production. So, but actually, insulin is not inevitable for muscles. Muscles can consume glucose even without insulin. So that's why. So it is not so affected. But yeah, in severe cases of deficiency of insulin, so muscles they use, instead of glucose usage for ATP production, includes protein catabolism, amino acids catabolism to produce ATP energy. So that's why yeah, of course it leads to polyphagia, also leads to gluconeogenesis process, but gluconeogenesis used to involve the glucocorticoid hormones. Okay. Then glucagon excess also causes gluconeogenesis. Okay, and about liver. So if consumption of liver of glucose is decreased, because glucose can appear inside the liver only with the help of insulin, so it requires his own glucose without not in plasma but from inside, and it leads to gluconeogenesis inside the liver, and due to gluconeogenesis, and it leads to formation of ketone bodies, and these ketone bodies are normally ketone bodies are produced in our body, so normally a little amount of them produced, but not in such large amounts as it happens in diabetes mellitus, and of course it leads to ketoacidosis. So ketoacidosis, it leads to diabetic coma. Diabetic coma due to, as I said, collection of the ketone bodies in the brain. Also this ketoacidosis causes kidney injury. Hyperglycemia also causes kidney injury by mechanism I explained before. So that's why by symptoms we can see this ketonuria. So we can see these ketone bodies in urine. It also leads to glycosuria because of hyperglycemia. I explained this mechanism. Glucose is removed from the kidney. And due to ketonuria and glycosuria, osmotic pressure of urine is increased, and due to this it leads to polyuria, and then it leads to volume depletion. Yeah, so it also can lead to diabetic coma, and but in milder cases it leads to polydipsia. So I hope you understood it. If you didn't, so the record of this lecture will be in YouTube, so you can observe it again. Or in written part here, so in this book, so also you can read it. So chronic complications, mainly I explained it, so in more details you'll discuss it in internal disease class. So yeah, one of things here I forgot to mention is microangiopathy, especially in cerebral region. So it leads to hemorrhages in the brain or thrombosis of brain vessels. Retinopathy happens due to vasculopathy of the retina. And then due to atherosclerosis, atherosclerosis is very actively formed in a case of diabetes mellitus. I explained it a little bit in previous semester. Yeah, due to blockage of vasoactive regions of the brain, vasoactive regions of the blood vessels with the atherosclerosis. So vasomotor region is not working properly. Then blood pressure is too much increased. Then thrombi all over the body are possibly present, and that leads to myocardial infarction. Also, it leads to nephrosclerosis. So nephrosclerosis, which leads to glomerulosclerosis, arteriosclerosis, pyelonephritis. So all of these conditions are happened due to increased glucose level in urine. It is a good source for bacteria settlement. Yeah. So bacteria can easily settle to this to urine, and it leads to cystitis, and secondarily leads to pyelonephritis. So and along with it, neuropathy is very commonly present, and due to neuropathy, so it maybe leads to autonomic nervous system neuropathy, and it leads to of course incontinence, for example, maybe incontinence, or opposite to this, so blockage of urinary pathways. In lower limb, it leads to gangrene because of peripheral neuropathy. So patient doesn't feel the leg, and bacteria which appeared here, they can involve entire leg with the gangrene. Okay, so in more details we'll discuss later. This is autoimmune insulitis. So this autoimmune insulitis. So what we can see here? So here we see islet of Langerhans. So this this is normal pancreas. So here you see this these cells are normal basophilic cells which produce pancreatic enzymes. But here islet of Langerhans. So this is normal islet of Langerhans, but around it we have what? We have immune cells. This is immune autoimmune insulitis. So it leads, and you see this signs of inflammation around it. Then and also it might be affected by amyloidosis, which is shown here. So you see amyloidosis we discussed a little bit. But yeah, amyloidosis is very uncommon. So let's skip it. So pathology is shown here. So for preparation of 4 classes, please prepare for it. This is complication to kidneys, which I explained, retinopathy discussed. So tumors of pancreatic neuroendocrine tumors, you have to keep in mind. So you see MEN1 and PTIN, so which inactivating mutations, which decreases the anti-tumor activity of cells. So and insulinomas cause the decrease of glucose level of blood. So and it leads to loss of consciousness. So loss of consciousness when the patient doesn't eat for few hours, for example. So because glucose cannot be reproduced, can be returned from glycogen to glucose. Then gastrinoma is the most common condition. It leads to the syndrome known as Zollinger-Ellison syndrome. So very interesting pathology. So especially in digestive tract pathology, we'll discuss it. It leads to overproduction of gastrin. So this enzyme which causes the activation of parietal cells, of the parietal cells of stomach, which produces more acid in the stomach, so which leads to ulceration of stomach. Okay, that's it. So let's talk about adrenal cortex. I will not spend too much time for it. So function of this we know. So it's a formation of glucocorticoids, mineralocorticoids, and sex steroids. So we discussed it in the previous lecture. Then adrenal medulla produces catecholamines. Catecholamines like adrenaline and noradrenaline, or epinephrine and norepinephrine, which is absolutely similar. Then Cushing syndrome. Cushing syndrome is happen when excess of cortisol, excess of glucocorticoids, named as Cushing syndrome, and we have different types of conditions which lead to Cushing syndrome. Hyperaldosteronism, so it happens due to excess of mineralocorticoids. And adrenogenital or virilizing syndromes, so due to excess of androgens happen. Especially it's visible in childhood. Yeah, so when a person with 10 years old male, for example, will act like he is a 16-year-old boy. So clinical features are different, so we'll discuss it now. What is a Cushing syndrome? So Cushing syndrome is a hyperproduction of cortisol by adrenal cortex. So it might be related to pituitary Cushing syndrome. So due to overproduction of ACTH, or might be ACTH overproduction might be happen due to lung cancer, which produce ACTH and also cause hyperplasia of adrenal gland, normal hyperplasia. So this is too much common cases. Third case is adrenal Cushing syndrome. So when we have a cortisol producing tumor or nodular hyperplasia of adrenal cortex, which produce cortisol, and we have iatrogenic Cushing syndrome. So when I said you before, yes, that in case of autoimmune disorders and in case of when we need to depress the immunity, we need to give to patient steroids, glucocorticoids. So glucocorticoid like hormone like drugs. and they cause adrenal atrophy in one hand, and secondly it leads to Cushing syndrome. So you see, Cushing syndrome is typically related to consumption of larger amount of cortisol and cortisol-like hormones. So 1 minute, stocks. So clinical features. Clinical features is here. Yeah, so this is typical photo of Cushing syndrome patient. So it's a typical this type of obesity where we have a large stomach, deposition of fat in a chest region, so more abdominal obesity, so a little bit in hands also, but legs are thin. So that's a very typical. Legs are thin. So thick neck, obesity of chest and especially abdominal region, but very thin legs. That's typical feature. And of course it leads to secondary diabetes mellitus, because these hormones are they lead to gluconeogenesis, and due to gluconeogenesis more amount of glucose is produced, and this glucose is it cannot be properly removed from the body, cannot be properly absorbed by the body with the help of insulin. Okay, then let's talk about, yeah, and of course immunity state is also decreased, so you understand it. So please, in internal diseases in details we'll discuss it. Mainly concentrate on causes of this disease. Okay, hyperaldosteronism. You know that aldosterone mainly causing effects of mineralocorticoids. Okay, so causes we discussed. And causes of hyperaldosteronism is very rare condition, so where aldosterone is increasingly produced, and it leads to hypertension first of all, because of increased sodium reabsorption, and hypernatremia is happens in this condition, and increased osmotic pressure leads to keeping of water inside the blood vessels, which increases the general volume of the blood, and it leads to hypertension disease. Okay, adrenogenital syndromes, okay, we can skip it.
Sir?
Acute adrenocortical insufficiency, yes?
Sir?
Yes.
Okay, sir.
Then let's talk about acute adrenocortical insufficiency. This syndrome is named as Waterhouse-Friderichsen syndrome. A very important syndrome, please remember it. So it happens in case of massive adrenal hemorrhage. And so this, in case of a massive adrenal hemorrhage, so it leads to apoplexy. Its name is apoplexy of this gland. And this when adrenal gland doesn't produce enough hormones, which can not only glucocorticoids but also adrenaline and epinephrine, so which keep the blood pressure. And in this case, we can say that acute adrenocortical insufficiency is like additional cause of death during the sepsis. Usually it happens in sepsis disease, or might be sometimes related to thrombosis of adrenal gland. And chronic adrenocortical insufficiency leads to different consequences. One of them is aldosterone insufficiency, which is known as where it's shown. So it's Addison syndrome, so I can't find it here. Addison syndrome, where decreasing of all the in glucocorticoids and mineralocorticoids, but mineralocorticoids are more prominent in this disease when we have decreasing of mineralocorticoids production. Then, so this we can skip, and then adrenal medulla tumor. So one tumor I explained you now. It's for me it's production of so this is known as pheochromocytoma. So pheochromocytoma, it has a lot of different cases. So please read about this. And this pheochromocytoma causes the formation of larger amount of adrenaline and noradrenaline, which leads to increased blood pressure. So especially after stress. So then little stress leads to expression of larger amount of adrenaline, and it leads to acute riseness of blood pressure. so which can lead to, in the peak of this, it can lead to hemorrhages in some weak blood vessels. Okay, if I'm not mistaken, that's it. Yeah, multiple endocrine neoplasia, it's for SRW, guys. Okay, thank you. Let me check attendance. So rapidly, and yeah, thank you, and you can go. Goodbye.
Thank you,
Goodbye,
sir.
sir.